You can diagnose circadian sleep disorders through either sleep logs or actigraphy. Light therapy is the preferred intervention. If the problem is getting to sleep at night, you want to prescribe 30 minutes of 10,000 lens of light. And again, the light boxes can be at the side. You don't have to be staring right at the light box. They just should be on the side, but close enough to your vision to provide retinal exposure. Conversely, if somebody has problems maintaining sleep, then that is 2 hours of light therapy early evening. Basically, you can also add low-dose melatonin. Start off low and let the patient know that it's not going to work immediately. Certain medications allow for some to sleep right away. Melatonin won't do that. It's going to take several days to week to kick in, and then if it doesn't work at the lower dose, then you gradually escalate it. You can use melatonin receptor agonists, particularly if there's low vision or blindness in the older adults. So that's an FDA-approved intervention in terms of REM sleep behavioral disorders. Also, age-related circadian disruptions contribute to neurodegenerative diseases, for example, Alzheimer's or Parkinson's, via clock gene dysregulation. Dampened rest activity rhythms show an association with aging. Plant-rich diets and balanced energy intake may modulate circadian health and delay aging. This is associated with excessive motor activity at night. I've got a little photograph here by Henry Fuseli that talks about the demons and your nightmares. This is often associated with Parkinson's and Lewy body dementia, and these are the individuals that come into clinic whose wife has a black eye from being hit in the middle of the night unbeknownst to the patient, or that they get a leg injury, and so forth. So, this is required to have polysomnography to make the diagnosis. So, for the REM sleep behavior, the treatment is melatonin in either Parkinson's disease. I'm showing Muhammad Ali, and his is what we call punch-drunk or Puglistica Parkinsonianism, and the other treatment for these REM sleep behavioral disorders could be Clozapine, but those are to be avoided in the older adult just simply because they have such a huge risk for falls and, like I say, amnesia. Here's our polling question for today's session. Which of the following is the preferred pharmacological treatment for REM sleep behavior disorder in older adults with Parkinson's disease or Lewy body dementia? A. Clonazepam, off-label, but avoided due to fall and amnesia risks. B. Melatonin. C. Trazodone. Or D. Cholinesterase inhibitors. The correct answer is B. Melatonin. Let's examine cognitive disorders such as dementia and sleep issues. Demented older patients have more sleep disruption. They get up in the middle of the night more frequently. It's poor sleep efficiency. It's not as deep of sleep, and it's overall just fragmented sleep. A lot of times they'll have that reversal of the day, the wakeful sleep cycle. So they're up at night and they're sleeping during the day. Here are some of the interventions for sleep disorders and dementia. You might want to avoid the cholinesterase inhibitors, such as Aricept and rivastigmine, because they may get vivid dreams and worsen their insomnia. We actually had a patient come in from assisted living with exactly that issue. She had just been started on a cholinesterase inhibitor for her moderate dementia, and so we discontinued that. The issue with sedative hypnotics is that they will increase falls, and they don't impact REM sleep. So those are to be avoided as much as possible, and you might empirically evaluate for obstructive sleep apnea. And the important point is that demented patients, certainly those that are moderate to mildly impaired, can indeed comply with CPAP therapy. And then finally, we would recommend bright light therapy depending upon what the sleep disorder is. If it's problems getting to sleep, bright light in the morning, or problems maintaining sleep later in the night, then it's bright light therapy in the mid-afternoon. There are both negative outcomes of sleep efficiency using melatonin, as well as data that shows that it does work. There are these so-called sedative antidepressants, such as mirtazapine and trazodone, and typically their sleep efficacy is at the low doses, and somatrazepine typically should be more towards the 7.5 dose on the trazodone, closer to the 25 milligram dose. But some randomized control trials show neither of them are very effective as sleep agents. Evidence also shows memantine for Alzheimer's disease improves sleep quality. With dementia, consider non-pharmacologic interventions. We talked about light therapy. There's actually one study that showed rather than 30 minutes, they did 60 minutes of light therapy in the morning to improve their sleep. Dance movements with familiar music is also a therapeutic approach. In one European study, they did home visits and talked about sleep hygiene with those home visits. Increasing physical activity, particularly before dinner time, is going to improve sleep hygiene and pharmacologic management. If you're looking at sleep issues, also address the caregivers for the older adult. They do lose a lot of sleep, and again, they have similar problems with sleep hygiene. It is exacerbated by depression, and it can really lead to caregiver burnout. When examining whether heat therapy and a hot bath improve sleep, there is some evidence that it does do that. There is a really fascinating study of regular Finnish saunas and several thousand Finnish men. The range was from 4 to 7 saunas per week, and you can see the hazard ratio declines with frequent sauna use. What an incentive for getting a sauna! Let's talk about the hospital-based sleep disruption. Certainly, the loudness of the environment contributes to that. People are waking the patient up at all hours, either for medications or for vital signs, so noisy. You're bed-bound. You know it's encouraged that you stay in bed as opposed to getting up and around, and there might be new medications that are going to disrupt your sleep. Whether they be IV or urinary catheters can also be a problem for sleep disruption. The approach is somewhat similar with some other considerations for dealing with the older adult with generalized sleep disorders or circadian rhythm disorders, so apply bright light. It is something that can be considered in the hospital setting. Changing the morning medicines to a later time as opposed to 6 o'clock in the morning, which may not coincide with the person's usual circadian rhythm. Try to avoid diphenhydramine because that leads to an increased risk of delirium, particularly if there's another anticholinergic medications on board. You can also prescribe melatonin again, with the caveat that it's not going to work immediately. It's something that may take a couple of days to kick in, if not weeks. As part of the Choose Wisely campaign from the American College of Physicians, avoid sedatives as a first line of therapy. You might consider a nighttime use of Tylenol and also other non-pharmacologic therapies, such as topical Voltaren or other liniment lidocaine patches that might address nighttime pain, and then keep an eye on the patient. Let nursing staff know, as well as others, to try and keep the older adult up during the daytime and encouraging physical activity as best they can. Simply just sitting in a chair and doing arm cranks in arm ergometry is beneficial. Chronic symptoms for insomnia typically needs to be referred to a psychologist for cognitive behavioral therapy, where they go through an actual sleep deprivation schedule to get the person's sleep pattern back on track. To encourage sleep hygiene, these are some of the things that you might put in your electronic medical record, smart phrase, or handout brochures to encourage the older adult to maintain a regular rising time, to use bright light therapy according to their symptoms, avoid napping, exercise, and to do so before dinner. Also to discourage reading or TV in the bed. The bed should be for sleep only, and also prep yourself 30 minutes before bed with mental relaxation, whether that be meditation or reading a non-tablet like a regular paper book would be useful, and then also applying white noise at the bedside. A big one is eliminating, or at least reducing alcohol. See about caffeine. A lot of times people don't always think about their Coca-Cola as being caffeinated, and certainly nicotine use, whether it's chewing tobacco or smoking, all can be stimulants that disrupt sleep hygiene. Again, trying to prep before bedtime, about a 30-minute wind down of some sort. You can also consider environmental elements such as earplugs or eye shades. In North Dakota, for example, During the summer, when it stays light up until 10 o'clock at night, getting eye shades may not be such a bad idea. Also consider body comfort. Simply putting on a good pair of woolen socks to help keep the feet warm is a good example of a sleep hygiene intervention. Importantly, if you can't get to sleep within 30 minutes, the recommendation is to get up and get to another room. Don't stay in the bedroom. Either do some meditation or do some short reading, and then try to readdress your sleep with all the other elements that we recommended here just a short time ago. Here are some of the non-pharmacologic interventions for sleep hygiene. As an intervention, it's important to recondition sleep behavior. There's cognitive behavioral therapy to reset the sleep cycle, but the most important prescription that we can do for sleep is to offer light therapy with 10,000 lumens. There's another technique where you tense and relax each muscle group. You start from your toes to your feet to your calves. You tense them up and then relax them, going all the way up to your jaws and neck muscles. That's a technique that you might instruct your patient to do as part of a relaxation routine as they go to bed. These are just some of the examples of what to expect. The stimulus control, where the patient is instructed to go to bed when they're sleepy, and to use the bed for sleeping and not for other activities. Also, try and avoid nighttime snacks shortly before sleeping. The sleep restriction is an opportunity to offset the sleep, so shorten the sleep stay and then increase it by 15-minute increments. The cognitive interventions include things like imagery and education about some false beliefs regarding sleep. It's important that with these individuals, you have to be mindful of them being cognitively intact. The demented patient does not really respond to rationalization or argumentative type discourse. Always remember that in the cognitively impaired individual, you always go with the flow. You don't challenge them. Those cognitive interventions aren't going to work so well in the demented patient. We talked about relaxation techniques. Whether it be a massage, vibration, a warm bath, or hot shower, mental imagery, or just meditation, these are all relaxation techniques that we're familiar with. Try to avoid the sleepers, all sedatives as well as SSRIs. The sedating SSRIs and all the antidepressive medication class increase the fall risk by 1.6 to over 2 odds ratio. These sleepers also contribute to amnesia, and long-term use may lead to dementia. Be careful with them because they can be associated with rebound and withdrawal syndromes. There's a lot of somnolence in daytime carryover because some of the even short-acting are not as short-acting as we may think. These are the different medications that you can consider: the trade versus the generic name, the starting dose, and some of the side effects. There was a study done on zolpidem that within 30 minutes of taking the medication, the older adults that were studied had a postural instability, the equivalent of a drunken sailor. It really was quite impressive that no sooner did they take the medication, that they had a tremendous gait disturbance and postural imbalance that was made worse by perturbation. The melatonin receptor agonists are listed there with some of the side effects. Melatonin is the preferred intervention. Suvorexant is another medication that can be considered. It has considerable side effects and carryover effects into the day that might affect driving. The low-dose SSRIs can be associated with fall risk and next-day driving impairment. New pharmacological options and guidelines show that daridorexant, dual orexin receptor antagonist, is recommended after CBTI per European Insomnia Guideline 2023. Updated AASM quality measures from 2024 for insomnia care emphasize multidisciplinary approaches, consistent sleep schedules, and avoiding long-term hypnotics. Chronic benzodiazepines increases overall morbidity and mortality. Overall, it will get short-term benefits, but it'll exacerbate sleep problems. It's really hard to convince people they really do have a true dependence. To deprescribe, it's important to do low and slow. Use half the dose every 2 weeks or every month to try and decrease the amount of medication that they're taking. Just words of caution, avoid Tylenol PM because it contains diphenhydramine or Benadryl. Try to get people to reduce their alcohol intake. Some of these over-the-counters, such as valerian and kava, really are not effective as sleep aids. In summary, you can use polysomnography for individuals that are not responsive to your sleep intervention, but don't use polysomnography for restless leg syndrome. Non-pharmacologic interventions for both insomnia and restless leg syndrome include bright light therapy, melatonin, and all those factors we talked about with sleep hygiene. Here are our references. We appreciate your attention and hope you've learned a little bit more about how to evaluate and treat sleep disorders in the older adult population. Thank you for your attention.